G'day and welcome back to the Broom Docs podcast. This is a vodcast and this is a review of the Profundus Trial. So, as some of you may know, I work in a big, busy metropolitan emergency department now, and we do worry about dissection, and this is what this trial is all about. How do we go about diagnosing dissection, and is there a better way using point-of-care ultrasound? Now, of course, this is a very difficult question and one that we often get wrong. So, interesting to look at this data and see what we can make of it. The Profundus trial was a trial that looked at a whole batch of diagnostic criteria. So they used a thing called the ADD score. They used POCUS views of the heart and other parts of the body, and also a D dimer to try and diagnose aortic dissection, but also to look for other sort of precursors such as penetrating atherosclerotic ulcers and intramural hematomas, which can present in exactly the same way. All right, so here is the conundrum that we face as emergency doctors. We know that we're very bad at diagnosing dissection. And in fact, in a previous case series of 321 patients, about 50% of them were misdiagnosed on their initial visit. So you could argue that missing dissection is actually the standard of care. And there was really not a big difference between the people that survived and the people that didn't survive when it came to being misdiagnosed on the first visit. So it was 55% in one group and 48% in the other group. So still within that sort of 50-50 miss rate. So this is something that happens a lot, and this is why this trial was done. Is there a better way to go about doing this? So here is the header of the trial. So the Profundus study group, diagnosis of acute aortic syndromes with ultrasound and D-dimer, and this was done in 12 emergency departments covering 5 different countries, so Brazil, Germany, Malaysia, Switzerland, and in Italy. Most of the authors and centres were in Italy, but they were scattering from other parts of the world as well. So a big multinational trial done by a large group of expert providers. And it should be noted that these were expert POCUS providers. These weren't sort of people that had done a weekend course. These were people that had done a lot of training. And when we get to the protocol, you can see why that may be important. So here is the actual protocol. I won't go through it all, but essentially to get into this trial, you had to be suspected acute aortic syndrome. Now that was a little bit vague in that the patient had to have symptoms for less than 14 days, and the basic definition was that dissection was a meaningful consideration in order to get into the trial. Now that's a little bit subjective, and so it does muddy the waters a bit, but we know from our experience in chest pain in the emergency department that there's chest pains and then there's chest pains, and we're always looking out for the acute STEMI because we know that that one we have a treatment for, and we're also looking out for things like PE and dissection because these are the ones that are really causing most of the mortality, which we can prevent. Dissection of those three is possibly the least well recognized and the hardest to diagnose, and so this trial was basically trying to say, can we sort that out? This trial's primary outcome was actually safety of their protocol. So the primary outcome here was looking at, did they miss any important dissections? So they had 1,979 patients from these 12 EDs, and their pretest probability overall was 9% of them ended up having an acute aortic syndrome, and the vast majority of those were the classic type A thoracic aortic dissections, and there were a few others that had intramural hematomas and PAUs as well. Now, you have to remember that because this trial was predominantly done in Europe, they tend to have a higher pretest probability than we tend to see in American trials and some Australian and other trials. And so just think about your pretest population. So, for example, in their high-risk group in this protocol, 400 patients got into the high-risk group and 35% of them actually ruled in, and 49 of those patients actually died. So this is a very high-risk group. And just think about your population. If you put every single patient with chest pain through this protocol, you won't get the same outcomes as this group potentially did. Although, having said that, they're doing it in quite a high-risk group, and it seemed to work pretty well. So we'll come back to that. It was a really well-done trial, and of the sort of nearly 2,000 patients, they only lost 4 patients to follow-up, which is quite remarkable at 30 days. I think that is an amazing job given that this was done in 12 EDs across multiple countries and languages. So really well done altogether. let's have a look at what the actual components of this diagnostic protocol are. So we start with a thing called the ADD score, or which you can grab off of the MD Calc, and then there's POCUS as well. And essentially, they combined the ADD score and the POCUS findings to categorize the patient as to either high pretest probability or low pretest probability. And then those two groups went through a slightly different algorithm in order to work them up further. So the low pretest group got a D-dimer. However, if the POCUS managed to pick up some indirect signs or soft signs, then they would immediately go over to the high risk algorithm. So, and they would go into advanced imaging in theory. So, interesting protocol, and we'll come back to maybe is there a better way to do that. So, let's have a look at the ADD score. This is the screenshot from MD Calc. The author here, Dr. Nazarian, is also one of the authors of the Profundus Trial. So, clearly has a lot of interest in dissection. And if you've listened to the Broom Docs podcast, or if you've listened to my buddy Justin Morgenstern talk about decision rules, then you'll know that we're not a big fan of them. And I think the ADD score is one of those decision rules that, by all means, you can look at it, but this is something that you should just do as a junior doctor. I don't even medical students should be able to take basic history, which gets you all of these features, and hopefully know when to be worried. So, patients that have a high pretest probability of their having a dissection, such as people with family history or have Marfan syndrome, or we know they have an abnormal aorta to start with, these are people that we're going to be worried about right off the bat. Obviously, that doesn't mean they're definitely having a dissection, but that should really make you think about dissection if you see any of those. The classic clinical story of the chest pain that's severe and tearing and radiating through to the back. Once again, that's just something that you need to ask and get right on the first instance. So if it's got any of those high risk features, you get a point for that. And then obviously on exam, there's features as well. So pulse deficits, focal neurological defects, a new murmur, and if someone's shocked, then obviously these are people that you're going to put into the high risk group. So although it's a neat little package bundled up score, I don't think it adds a lot to what I would deem to be just good clinical practice at the end of the day. So they did dichotomize this score into people that had one or less or people that had two or more. But the problem with this type of decision rule is that when you look at it, you could have two pretty soft signs, such as, a family history of aortic disease and maybe a small perfusion deficit between your limbs, and that would get you two. And that's still not a patient I'm really super worried about. Whereas if I've got someone that has severe intensity, ripping, tearing back pain that comes into the ED with chest pain, they're already in the very high risk group, even though they only score one on this ADD score. So I think you need to use a bit of common sense, and I think we dichotomize this in our heads as, yes, this patient looks like crap, and we're going to work them up, versus the rest where we sort of go, we're going to work them up with our standard chest pain pathway. So useful possibly, but I think this is essentially what med school's for. Let's talk about the POCUS examination that they did, and this was quite an advanced POCUS examination. So I don't think that in Australia, at least, and many I've taught around the world on various ultrasound and echo courses, I don't think that the standard ED doc is doing these views. Even some of the more advanced practitioners that I work with probably aren't doing suprasternal views on a routine basis, and they can be really tricky. And so I think when you're looking at a trial like this, you need to appreciate the level of provider that you're dealing with. And if you're thinking that this is something that you could do, you need to really ask yourself, how good am I doing echo, and can I reliably get these views? Because even in the best hands, suprasternal views can be very tricky, and I don't know that we're really as good as potentially these authors are. So have a bit of a think about that. So essentially the features that were present on POCUS that they were looking for, obviously if you see a flap either on the parasternal long axis view, which is item B, or if you see it on the suprasternal notch view, which is item C, then a flap is usually the gold standard on echo that we look for to identify a dissection. They also looked at things like the wall thickening or the dilatation of the proximal aorta, which is number D, and over 40 millimeters seemed to be the cutoff. They could see a penetrating ulcer, which is item E, which is a little cragged looking ulcer within the aorta at any point. F is looking at dilation of the proximal aorta. G is also looking at aorta, but just on the diameter on the suprasternal notch view. H is looking for a pericardial effusion, and I is they defined as aortic regurgitation, jet at least moderate in severity. So that's suggesting that the aortic valves aren't coming together, usually secondary to dissection or a dilated aorta. And then they sort of categorize these into 3 different groups. So the patients could have direct signs, which was the flap, essentially. Number 2 was crescenteric thickening more than 5 millimeters of the aortic wall, which is what an intramural hematoma can look like. And number 3 was that jagged little PAU ulcer in the wall of the aorta at any point. So if you had one of those 3, that was called a direct sign. Indirect signs were things like having a thoracic aortic dilatation more than 40, the presence of an effusion, the aortic regurgitation jet, or the providers were allowed to go looking up into the carotids, into the abdominal aorta, or down into the limbs. So if you see a flap elsewhere, then obviously that makes it much more likely that this is in fact a dissection. It's an interesting one that it was made an indirect sign, because I would have thought that someone with chest pain and a flap in their carotid artery would be a direct sign, because you're seeing the flap essentially, even though you may not see it closer to the heart. But that was made an indirect sign in this trial. And then there was the group that had no POCUS findings whatsoever. So I've had a look at the data from the trial, and I've rearranged it into this little nifty table, just looking at how potent each of these ultrasound findings are in terms of, was there an aortic syndrome or was there not an aortic syndrome. So if we look at the first line there, if an intimal flap was seen, 41% of the patients who had a rule in, so they were finally diagnosed with acute aortic syndrome, had a flap seen. But interestingly enough, 1.2% of the patients that didn't end up getting the diagnosis of acute aortic syndrome also had a flap seen. So it's quite a potent discriminator. So it's 35 times more likely if you did rule in. So that was the most reliable sign. And that's what we all sort of know from our practice, is that seeing a flap is bad news, and that patient definitely needs a workup with advanced imaging and almost certainly has a dissection. But obviously there was a few that didn't, and my guess is that some of those were probably artifactual flaps or possibly chronic flaps, which can happen as well. And then as you go down the list here, intramural hematoma was about 10 times more likely in the ruling group than the group that was ruled out. And penetrating ulcers, once again, very small numbers. There was only a couple seen, and they were around that same 10 to 1 ratio. So if you had any of those direct signs, you were 27.5 times more likely overall. But to be honest, the ones that we really care about are the proper dissections, and that's the top line there, the intimal flap seen. So these others can be quite difficult to diagnose in my practice, and I think they're probably interesting to know about and probably do need to refer along for follow-up, but they're not the ones that are going to kill the patient today. When they looked at the soft signs, so aortic dilation was about 6 times more likely in the ruling group than the not ruling group. There was a really nice cutoff of 40 millimeters between, so no one that ruled out had one above 38 millimeters, and all the patients that ruled in were above 40 millimeters. So if you use 38, 39, 40 as your cutoff, depending on what you want to make your sensitivity or specificity, that's a pretty good number to remember. The presence of a pericardial effusion was not that great, and we know that there's lots of other causes of an effusion, so that's probably why. And the presence of aortic regurgitation was also mediocre in its discrimination. Obviously, there's other reasons for that as well. So that's just a look at the actual data that people, these providers were able to give us. So useful to know, and I certainly will take that forward into my practice. So the gold standard, and what you're really looking for, is the flap, and the rest of it is sort of useful and can help you push maybe lower risk patients one way or the other, and that's how they used it in this trial. So once they'd done the ADD score and the POCUS, they then decided if the patient was high or low risk based on their scores, and the ones that were in the high risk group just went straight off for imaging, and the low risk group then got a D-dimer. Now, D-dimer is probably not standard of care for diagnosing aortic dissection, and it's something that's been becoming more and more popular and has been studied quite a bit in recent years. And essentially, when you look at the numbers for D-dimers for dissection, it's very similar to the numbers that you get for workup of a pulmonary embolism. So you can probably think about it in very much the same way. It's a very non-specific and relatively sensitive test. If you want to hear more about the role of D-dimer for dissection, I suggest you go over to the SGEM, listen to episode 454, where Ken and I talk about dissection and dimers for about 45 minutes, and you can get all the data that you need from on that particular podcast. So go and listen to that. But in the meantime, you can just trust me that the numbers from the meta-analysis and in this trial were all roughly the same. Sensitivity in the sort of 96-97% range, specificity around a coin toss, not a very good positive likelihood ratio, but a reasonably potent negative likelihood ratio, which allows you in a lower risk cohort to probably exclude dissection and send that patient home. So what did they actually find in this trial? So the bottom line was that they essentially had no misses in their rule out group. So in the patients who they took to the ED and did the integrated risk assessment using the ADD score, which is history and exam, and then also doing the POCUS, the ones that had nothing on any of those, or less than one or less in the ADD score, got a dimer. And interestingly, the use of a age-adjusted D-dimer was perfectly valid in this cohort and improved the specificity from around 52% up to nearly 60%. So you get a bit more specificity if you age-adjust your D-dimer, and I think most of us should be doing this nowadays. And they didn't miss anyone. So essentially they had 100% sensitivity, if you believe that. Obviously, nowhere in the world is 100% specificity, sensitivity a real thing. So if you look at the safety margin, the worst case scenario in the 95% confidence interval was a miss rate of 1 in 244, just under 0.5%, which is acceptable to most emergency providers, I would hope. This was a very POCUS heavy, so all of the patients got a point of care ultrasound. And as you can see, that's not a simple scan. It's not a quick look. This was multiple views, and you had to get good pictures. So very POCUS heavy. Obviously, the specificity of the protocol was still only in that 50 to 60% range, so you still end up doing a lot of CTs. However, the study authors said that essentially they could avoid advanced imaging in 2 out of 5 or 40% of the patients that they put into their trial. So that's potentially a useful thing to know. If you use this protocol, you might avoid CT in some patients. Of course, you need to look at your own population and your own practice before you make that decision. An interesting thing about timing that I pulled out of the data here was about what happens in reality in this trial. So we know that dissection is a bad disease, and if you delay the diagnosis, that you have increased mortality. And some trials would say 1 to 2% per hour increased mortality. There's a steep drop off in the first 24 hours. So it's quite important that we do make this diagnosis and get the patient into theatre if they have this diagnosis as soon as possible, because that can save a lot of lives, obviously. So if you look at what actually happened in this trial, the patients that had a POCUS sign that was positive, so had any positive POCUS sign, their time to definitive imaging was 60 minutes, and the ones where the POCUS was negative, it took 2 hours for those that ended up ultimately getting imaging. So we sort of know this from our practice as ED POCUS providers, is that we do tend to accelerate the diagnostic process. And certainly that's what I've seen in my practice is you see someone, you put the probe on, you see something that's worrying on there, and that is enough for me to make a call to the radiologist and say, can we do this patient next and not after the 3 ladies that are waiting to have their gallbladder scanned in the CT, because this is something that actually does make a difference. So this is one where I would get on the phone and talk to the radiologist and get things moving a bit quicker. This trial also had a relatively slow D-dimer turnaround of between an hour and a half for D-dimers, which is tricky because obviously the D-dimer was done later in this protocol. But I think in this low-risk cohort, I'll come back to this later, but I don't know that we need to POCUS them all. And so if you can get a dimer quicker, that may be useful in this particular low-risk cohort. We'll come back to that again. So a few criticisms of this trial. The order of testing is a little bit unusual for me. The fact that they put the ADD score with the POCUS in order to risk stratify, I think is a little bit unusual and a bit problematic, because that's not a quick echo that they're doing there. It's going to take a bit of time. And I think for the low risk group, so people that have a low risk ADD score or clinically just don't seem likely or are equivocal, I think doing a dimer on that patient without doing an echo is probably enough to send them home. And you could avoid a lot of echo time as well in that low risk cohort if they have a negative dimer before the echo. That's not something that I can say, but that's just my gut feeling from reading a lot of literature and looking at this trial, is that in the very low risk clinical story, a dimer is probably adequate to send them home and is also obviously useful for excluding other important diagnoses. The trial that was done here by the Profundus group, they didn't actually record or have any sort of QI or inter-rater review of their imaging, which I think is a big miss in this trial because we know that POCUS is imperfect. For example, 1.2% of the patients who had a flap turned out not to have acute aortic syndrome. So I think that this would have been something that, although it is time consuming, would have been really useful to do, because then we would have been able to look at this expert group and see how good they were. If you record your clips and your stills, send them off, and 3 other people look at them, and then you get a look at and see how many people agree with your findings or your measurements or whatever it is that you're saying is a positive feature on that echo. That would be really useful information to know exactly how good we are at doing these echoes and what our miss rates might be, or how bad our interrelator observer reliability is, because I think that it's probably less good than the authors may have thought it is. And they actually say in the paper that they think that it's pretty good, but there's certainly a bit of evidence out there that suggests that echo, particularly when you're doing tricky and advanced views, is probably worse than we think in terms of agreement between different readers. And then the last thing, which also I think would have been very useful, is that a lot of the patients, obviously, these patients aren't coming in for a workup of dissection. They're coming in for a workup of their chest pain or their neurological symptom. And there's a lot of important differentials here. So PE, acute MIs, other bad chest things, stroke, etc., that we could be knowing more about. And so, although they followed all these patients up for 30 days, they didn't actually give us the data for the ones that turned out not to have an acute aortic syndrome, what the alternate diagnosis was, and did this protocol actually help? Like, did doing an echo and a D-dimer actually help rule in PEs more or find more AMIs faster? That would have been really useful to know. So, although they've given the mortality data, they haven't actually given us an actual reason for that mortality if patients died of other causes other than dissection. So that would have been really nice to see as well. Anyway, overall, it was a really well done trial, and I just thought those were points that if I was going to do this trial again, I'd probably want to know more about. So after reading all of this, I've had a bit of a think about it. We've discussed this at our advanced ultrasound group, and there's a couple of things that I think I would do differently if I was going to include this trial in our future practice. And certainly it looks safe. So this protocol looks like it didn't miss anyone, which is very reassuring, and is probably better than our current standard, which is essentially clinical exam and hope and pray, and it's very variable, obviously. Here is the protocol that I would probably use after reading this and reading all the evidence around this. So I'm not a fan of the ADD score, and I think essentially emergency docs are bright enough to take a history, do an examination, and then at the end of that say, this is someone who either sounds like they're having a dissection, and if your little alarm bells are going off in your head because something you hear on the history or exam or something you look at makes you think this is possibly a dissection, then they should probably just get an urgent echo, because what this trial does show us is that doing an echo seems to expedite the advanced imaging. So this is how I practice. If I'm taking a presentation from a junior doctor trainee and they say to me, oh, I've got this patient's got chest pain and it went through their back and they felt a little bit weak on their left side for a minute, I get off my chair and pick up the probe and go straight to the patient, because this is someone who I may be able to bump up the queue and get scanned ASAP. And if the echo helps me achieve that, then great. So I think that group's relatively easy. And we all sort of know these patients, get the story, you think this is a dissection until proven otherwise. You can either go straight to CT, but I would be activating the cardiothoracics team. And once I've got the echo finding something that looks like a dissection flap, then, you get all the bells and whistles happening. You get the surgeons to the table, you alert theatres, you get everything going because the clock starts ticking as soon as you see something. The relatively benign sounding chest pain, so the 25-year-old that fell playing rugby and now has chest pain, fine. You can do whatever you want with them. Get an X-ray, manage them as per your normal chest pain pathway. Do whatever you need to do. Those are also the easy group. The group in the middle are the patients that we get presented a lot, where it's uncertain. Like, it's a maybe. You're not really sure. They don't have any hard signs to make you think, I'm definitely going to push this patient into CT. But you're sort of thinking maybe they could have a dissection. It could be a STEMI, but the first troponin's negative and you're not really sure what's going on, or the ECG is not that concerning. These are the patients that I think the D-dimer before the POCUS would be useful. So if you can get a fast D-dimer, that would be much more useful, and you should definitely age adjust your D-dimer based on this data. And so if you've got the patient that's in that no hard signs, clinically you're not really sure, you don't think it's a STEMI, you don't think it's a PE, you don't think it's gastric esophageal reflux or anything, then give them do a D-dimer. If that's negative, then you're probably below the threshold of what you need to do. Or you could do it if they have a positive dimer and they don't have any hard clinical signs, then they can then have an echo, but it doesn't need to be done ASAP. And you're doing an echo here for a different reason. You're doing the echo to look and see if you can rule anyone in, because they've got a positive D-dimer, but you also may see other things, such as pulmonary hypertension, making you think, oh, this is possibly a PE. So this is a patient with an equivocal story, a positive D-dimer. You've done an echo, and here you're looking to broaden the differential, not just looking to rule out dissection, but also looking to rule in other things, such as a PE, for example. So that's sort of the way I would play this. There's two different types of echo. There's the echo to get things moving ASAP, and then there's the echo to work out what's actually going on in your patient, which we also do a lot in our practice in emergency. So that's the way I would do it, and I'd be interested to hear your thoughts. If you have any comments, please leave them in the comments below, or hit me on Blue Sky, which I am now on, so you can go and have a look. And we'll be discussing this trial, I'm sure, on the Broom Docs podcast with Justin at some point in the future. All right, see you later.